Hey guys, Chris here from Lifeline EMS Training. Today we're going to talk about, STEMI, now what? So what do you do when you see STEMI go across your monitor? You get this question a lot, or get this question on calls. Oh, we got a STEMI, let's call it in. What else do we need to do? Let's talk about it. So you have your monitor, you dial up your 12 lead, have the patient hooked up, you're concerned about the low end tidal, low blood pressure. EKG kicks off and you get STEMI on the monitor. Meets ST elevation MI criteria. So what do we do next? Well, of course, we call in the alert, right? So we get on the horn, let the receiving PCI center know that we're bringing them a STEMI patient. And then we need to set our immediate priorities before we start jostling the patient and moving them around. The first is get the pads on. And don't just say, hey, we're putting these pads on you in case you die. We have to shock you, right? Because this person's having a heart attack. And if their pump is broken, what is the ultimate break of a pump? Arrest, speeding up, stopping, cessation, right? In our world, VFib or asystole. So we want to have the pads on in case they go into a shockable rhythm and we need to shock them quickly. Have some swagger when you do this. Hey, we're putting these two pads on just so we can get a bigger picture of your heart, a different picture of your heart, a better picture of your heart. Don't let them know you're putting these pads on in case their heart stops. You're going to shock them with tons of direct current. But pads should be one of your early priorities because you don't want to get punked by a sick heart crashing and coding. Second, make sure you have the aspirin on board. Most of you just gone to the 325, so the 481 milligram tablets. Make sure they chew them. Make sure they're baby aspirin. They're enterically coated. You don't want them sitting and slowly absorbing in their tract over 4 hours. You want them to be absorbed quickly so they have the antiplatelet effect so that the clot in their artery does not continue to get bigger and bigger. You want those platelets to become slippery so that that clot is not becoming worse. Vascular access. Well, so vascular access is one of those things where a lot of people just put one line in and they just leave it as a lock. Fluid is the friend in this patient. We'll talk about cardiac output, heart rate times stroke volume here in a second, but there's also a couple of the things to be considerate about when you're putting in your IVs. So either the ACs are great, left hand is great. The right hand, try and stay away from. We'll talk about that why here in a bit. Also, if you can, get 2 lines and give fluid, at least a 500 ml bolus. You want to get them filled up. You want their container full. And we'll talk about why that catheter can be tickling the baroreceptors when they're going through in the lab and can trigger the heart rate to drop, decrease the cardiac output. So you keeping them volume resuscitated or volume full actually makes them floating that catheter a little bit easier and the patient less susceptible to dropping their perfusion status. So why the right hand? Why do we stay away from the right hand? Well, the 2 places they actually go are the femoral artery when they're placing a cath, so floated up through the femoral artery, or the right radial artery. So the right hand's radial artery, and that's because it goes right over out through the arm into the subclavian, right down, drops the aorta, and then they can hit those 2 coronary os for the left and the right coronary artery. So the femoral artery, they'll float a catheter up and in, or the right radial artery, they'll float a catheter up and in. And they actually prefer the right radial artery because it has less complications post. They can just put, looks like a little, one of those nausea pressure bracelets. They put it over top and allows to maintain pressure down. And it's not in a damp, moist area like the femoral artery is, less infection rates, less bleeding complications afterwards, easier site management. So it does actually mean a lot in the long run. And it's not that putting an IV in the back of the right hand inhibits the arterial function. What it does is when you put that catheter in their hand, it reduces the mobility and the flexibility of that right hand for when they're putting the cath in. And they're actually for the ease of the work that occurs around that area. So it's not that it like stops the arterial flow, because that's not the case for putting our cannulas in the vein. What it does is it kind of bogs down the area that needs that flexibility, motion, movement, placement for them to float that catheter through. And so how do they test to see if the right radial artery is a candidate? Well, they do this thing called an Allen's test. And it's not an Allen wrench test, it's an Allen's test. And what's checking for is ulnar artery sufficiency, because if they're going to be floating a catheter up the radial artery, it's going to be blocking that blood flow. And so they need to make sure that the secondary or the second artery, in this instance, the ulnar artery, actually has sufficient flow to the hand so it doesn't impact them. So what do? Well, have the patient make a fist with their right hand. So they make a fist, and the clinician takes two fingers, as you see over here, and they block the radial and the ulnar artery while the fist is closed. Then while both arteries are blocked, they ask the patient, hey, open up your hand. They open up their hand, and then they release the ulnar artery. And what they're looking for is that hand to go from that blanch white to that red perfused again in less than 5 to 15 seconds. And that says, hey, they have good, sufficient ulnar flow. So what does that look like? This is what it looks like. So you have the patient clench their hand, block both the arteries, open your hand up, and you can see in this instance it's blanched. And now we release the ulnar flow. And we want to see that hand get red. See, I've got red there in definitely less than 5 seconds. That's a good, sufficient ulnar flow to that right hand. This patient, in this instance, Ryan, would be a great candidate for a right radial catheterization. So some other things that are going to happen with that STEMI, because you get a lot of people like become hyper-focused on the door to balloon time. When I arrive on scene, they should take my patient right to the cath lab. Well, they need to register them first. So have the ID ready. Most places, the cath lab has to have the patient registered through the emergency room. So have the ID ready. They're not racing them right to the cath lab in a lot of instances unless they have this down. So the other thing they like to do is a chest x-ray. And this is not because we're incompetent providers. What they're trying to do with a chest x-ray is to make sure they don't have an aortic dissection that is causing, in this instance, a DeBakey 1. So right at the ascending aorta, that when that wall is actually becoming flappy, so that's what this is right here. This wall is actually dissected, delaminated, and it's flapping down. And this is very drastic. So this would be like a bilateral. It's blocking both of the coronary os, or the holes to which the coronary arteries get their blood flow. So if this sloughs down here and blocks those two coronary holes, that's a problem. And if those coronary arteries aren't getting oxygenated blood flow, they can mimic an ST segment elevation MI on the EKG. So what they need to do is they need to rule out that it's not aortic dissection, because that's a little different of play than just going in with a catheter and trying to find where the clot is in the heart. And what this picture is a chest x-ray with that dilated aorta widened here on that chest x-ray. So this would be an instance where they would change the play up, because this person actually is having a dissection versus a scab forming in one of their arteries in the heart that's causing reduced blood flow. So heart, again, this is where they float the catheter, subclavian, up, down aorta, and then they go into either the right or the left coronary os when they're doing that. What are they using? They're using one of these little cath guide wire stents here. They actually have like a little roller ball in there. It almost looks kind of like the IV clamp, and that roller ball actually controls the end of this catheter right here, and it whips the kind of pencils around, like squiggles around like a drunk little worm when they're trying to find where they're going. And when they're doing that, they're actually squirting dye, which we'll show you here in a second. But the reason your volume resuscitation, back to what our third slide, is very important is because the aortic arch has those baroreceptors. And as they're coming down and they're wiggling that catheter around, they can trigger those baroreceptors and create pressure changes or response changes in the body, because the body thinks perfusion pressure is higher. So here's the aorta. At the base of the aorta, those two coronary os, those little holes where the coronary arteries get their blood flow on diastole. So if that catheter whips up here and bounces around and catches that baroreceptor, you may create an increased pressure sensation from the triggering of that receptor and cause a dump in their heart rate. So cardiac output, heart rate times stroke volume. Remember, stroke is down because they're having a heart attack. So contractility is affected. Heart rate's now down because we've triggered those baroreceptors. So back to that volume you gave, that's why volume is a benefit to them, is you keep them filled up and help them get through that triggered hypoperfusion state we've kind of tricked them into. So when that catheter migrates down through here, they go and find which coronary os they're looking for. And they're constantly spraying this radioluminescent dye, which is when you saw in the cath lab picture, they have that C arm that goes around the patient. That's that fluoroscopy. And as they're going and squirting, what's happening is that dye then shows the mapping. So over here, this is where there's a blockage. And now they squirt, squirt, squirt. They put a stent in, and now they've reperfused this area, and they can see that now by squirting that dye as they go through. So that's a review of, so I have a STEMI. Now what? Some of the things to just be aware of you need to do, to prep for and plan for, ensure that are done. And then also just expectations on what happens at the hospital and why your patient isn't rushed downstairs immediately because you called a STEMI alert and the cath team isn't sitting there going, oh, thank you so much, and immediately floating a cath. There's some other things that have to happen, little basic things like registration, chest x-ray. They may take the cath team an extra second to get the patient who was previously on there on board. That's why it's great to call early. We always make the joke, call from the patient's phone. That's not necessarily using their anytime minutes, but the logic is call while you're still at the patient's home or bedside or office cubicle, so that gives enough reflex time to the cath lab to either clear the table or to get them in. Most cath labs where the crews aren't there 24/7 have a response time of 30 minutes. And that's from the time they receive the call to the time they clock in the hospital. Still have to go to the lab, turn on everything, get everything prepped. So it takes a little bit of time. We hope that helped. As always, if you have any questions, hit us up at info@lifelineemstraining.com. We hope you have a great day.